Welcome to Dr. Baliga's podcast for the Kurious Doc. Today is May 9, 2026. This video is on uh, two articles, one in the Lancet and one in JAMA, and there are two accompanying editorials. The Lancet article is titled Long-Term Effects of Colonoscopy Screening on Colorectal Cancer Incidence and Mortality, a multi-country population-based randomized control trial. The accompanying commentary in the Lancet is titled Colonoscopy, Cancer Prevention, and the New Arithmetic of Benefit. The JAMA article was published, the Lancet article was published on May 4th. The JAMA article was published within the last month on April 9th, 2026. The original JAMA article is titled Colorectal Cancer and Mortality Risk Among Older Adults with versus without adenoma on prior colonoscopy. And the accompanying editorial is titled Assessing Colorectal Cancer and Mortality Risk in Older Adults. The Lancet article, the design multi-country randomized trial, 84,583 adults aged 55 to 64 in Norway, Poland, and Sweden. There was an invitation to colonoscopy versus no screening. 11,841 of the 28,217 invited participants attended colonoscopy, yielding a 42% participation and a 13-year median follow-up. The incidence of colorectal cancer was 1.46% versus 1.8%, risk ratio 0.81. The number needed to invite was 294. Mortality, colorectal cancer death was 0.41% versus 0.47%, risk ratio 0.88, not statistically significant. Gradient benefit was stronger for distal tumors for men and those invited at the age between 60 to 64 years. The bottom line, a single colonoscopy prevented some cancers but did not yet reduce deaths. What does the accompanying commentary say? Prevention, prognosis, and price, the new arithmetic. This NordICC reframes colonoscopy from gold standard saves lives to prevent some cancers with modest absolute benefit. Prevention, the invitation reduced cancer by 0.34 percentage points per protocol estimates. Approximately 8 cancers prevented per 1,000 screen. Mortality, colorectal cancer deaths remained low and non-significantly different. All-cause mortality was nearly identical. Benefit was clearer for distal than proximal tumors with a stronger signal in men. Context, improved colorectal cancer care compresses the incremental mortality benefit of screening. So the policy implications, balance colonoscopy against fecal immunochemical testing, treatment pathways, and opportunity costs. The JAMA article, it's a VA retrospective cohort of 91,952 adults aged 75 or older with colonoscopy before the age of 75. Prior adenoma in 25,538 and no adenoma in 66,414. Median last colonoscopy age was 71 years. Cancer, 10-year colorectal cancer incidence was 1.1% with adenoma versus 0.7% without adenoma. Colorectal cancer death was 0.5% versus 0.4%. Statistically higher but clinically small. Competing risk, non-colorectal cancer death was 46.9 to 48.4% among adenoma patients. 34.2 were non-frail to 82 were severely frail, meaning surveillance after the age of 75 should often yield to frailty-informed priorities. What did the editorial say? Colonoscopy is powerful prevention, yet surveillance decisions often default to polyp equals repeat. The problem, life expectancy calculators miss frailty, cognition, physiologic reserve, and chronic disease dynamics. This original JAMA article shows colorectal cancer events after 75 are uncommon, while non-cancer mortality dominates. Uncertainty, generalizability to women is limited because the cohort was 98% male veterans. Clinical practice, gastroenterologists should partner with primary care and specialists to individualize surveillance. Future electronic health record and AI tools may quantify frailty and guide shared decisions. Clinical pulse. Colonoscopy is a cancer prevention tool, not a mortality magic wand. Absolute benefits, small relative reductions may translate to many procedures per event prevented. Distal colorectal cancer appears more preventable than proximal disease. Quality and anatomy still matter. After the age of 75, prior adenoma increases risk, but competing mortality usually towers over colorectal cancer risk. Frailty should be a co-pilot in surveillance decisions. Age alone is a blunt instrument. Screen wisely, surveil selectively, and redirect capacity to unscreened high-risk patients. This is an infographic. Hit pause and read at your leisure. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.